In the second part of my lecture, I will talk about observational study. Epidemiologic research assumes disease occurrence is not a random event. Systematic investigation of different populations can identify causal and preventive factors of diseases, and making comparison is the key of systematic investigation. The natural progression in epidemiologic research starts with suspicion. Suspicion that a factor influences disease occurrence. This can be arises from clinical practice, lab research, examining disease pattern by person, place, and time prior to epidemiologic studies. The next step is formulation of a specific hypothesis. After we have the hypothesis, then we conduct epidemiologic study to determine the relationship between the exposure and the disease. We need to consider chance, bias, confounding when interpreting the study result. Finally, we need to decide whether association may be causal or not, and might need to consider other research to look at strength of association and time directionally. Observational study. This is one of the most important study design in epidemiology. Observational study, all individuals observe already under their respective condition. This is like a natural experiment where the observer or researcher does not interfere with their exposure. However, when comparing the two groups may differ in way others than just the observed condition or exposure. So we must aware of the possible confounding factors. I will start with cross-sectional study. This study also known as survey, where we assess the health status and exposure levels of person in a population at one point in time. This is like a snapshot of disease present in a susceptible population during a specified time period. Cases with developing condition that have not yet been diagnosed are not counted. In cross-sectional study, we collect all information about current disease status and exposure status at the same point in time. The strengths of cross-sectional study include: this is the primary method of estimating prevalence, logistically efficient because this study is relatively fast since no follow-up required, and we can enroll large number of participants in one study. And cross-sectional study can be conducted for many exposures and diseases. However, there are limitations of this study design. They are useful to discover association, but incapable of determining if one factor caused the other. Case control or cohort study are often used to verify their results. Large number of sample size are required for rare exposure or outcomes. No information on timing of outcome relative to exposure or temporality. And this study includes only those individuals alive at the time of study. Next is cohort study. This is also called follow-up study. By definition, cohort study is study in which person, based on their exposure to a determinant and free of the disease outcome at the end of the study, are followed in the time to assess the occurrence of the disease outcome. In a cohort study, an investigator select a group of non-diseased people and follow them over time to determine if they develop a disease or outcome. A famous example of cohort study is Framingham study. Started in 1948, where researchers recruited more than 5,000 men and women between the age of 30 and 62 from the town of Framingham. The aim was to identify risk factor for cardiovascular disease. Participants were followed up for every 2 years. For example, one of the objectives was to look at the association between hypertension and myocardial infarction. At the start of study, they identified those with and without hypertension, then later follow up for how many developed MI. Since cohort studies start with disease-free population, it is suitable to study rare exposure and it is possible to study multiple outcomes. However, since this study involves follow-up, it usually takes longer time to complete and expensive. A cohort study can be prospective or retrospective. In either case, the subjects are selected according to whether they are exposed or not exposed to the factor under investigation, and their subsequent disease status is ascertained. The feature that distinguishes a prospective from a retrospective cohort is simply whether the outcome of interest has occurred at the time the investigator initiates the study. Case control study is another important study design in epidemiology. This study also called patient control study. By definition, case control study is a study in which patients with the disease outcome and a control group without the disease outcome are selected, and in which it is determined how many people in both groups have been exposed to the determinant. Case control study, a study that compares patients who have a disease or outcome of interest with patients who do not have the disease or outcome or controls, and look back retrospectively to compare how frequently the exposure to a risk factor is present in each group. This is to determine the relationship between the risk factor and the disease. Because the cases were identified before obtaining the exposure, temporality between cause and effect difficult to establish in case control study. Example, in the 90s, there was an epidemic of CJD in Europe. CJD is a fast progressive form of dementia. This disease was caused by eating infected beef. Patients with CJD were selected and compared with non-CJD patients. Then, patient history of beef consumption were questioned. So, case control is retrospective in nature. Since this study starts with disease population or cases, it is suitable to study rare disease or outcome, and it is possible to study multiple exposure. Case control study also relatively need shorter time to complete and inexpensive. Next, I will talk about measure of association in epidemiology. The chances of something happening can be expressed as a risk or as an odds. Risk is the chance of something happening divided by the chances of all things happening, whereas odds is the chances of something happening divided by the chances of it not happening. Relative risk and odds ratio are the main measure of association in epidemiology study. Relative risk use incidence to assess risk, compare the incidence in exposed group to incidence of non-exposed group via risk ratio. Okay, now I'm going to show you how to calculate relative risk. So, for example, if we follow up 100 of hypertensive patients in a cohort study compared to another 100 patients of non-hypertensive patients in the same study, and at the end of the study, we want to know how many of them develop myocardial infarction. So, for example, in this case, at the end of the study, 14 of the patients among the hypertensive group will develop MI, whereas only 7 of the patients in the non-hypertensive group will develop MI. So, to calculate relative risk, we need to calculate the incidence of outcome or cases in each group. So, for example, in this case, the incidence of MI in the exposed group is equal to 14 over 100 or 14%. And the incidence of MI in the non-hypertensive group or the control group is equal to 7 over 100 or 7%. So, to calculate relative risk from here is just simply the incidence of exposure divide the incidence of in the control group. So, in this case, the relative risk is equal to 2. What it means that the risk of the patient who have hypertension to develop MI is actually twice or 2 times more likely risk of patient without hypertension to develop MI. Okay, from this table also we can calculate risk difference. So risk difference is simply just the minus of incidence of cases in the control from the incidence of cases in the exposure. So risk difference We take the incidence of exposed group. From then, we minus the incidence of cases in the control group. So in this case, the risk difference is equal to 14% minus the 7% or equal to 7%. So risk difference also is known as attributable risk. So what it means that the risk of you having MI due to hypertension is actually 7%. In case control study, exposure level are determined by looking back in time before the person became a case or a control subject. Because case control study are retrospective, we cannot determine the risk of developing a disease. But we can estimate the odds of developing a disease given that a person was exposed to a risk factor, the odd ratio. The odd ratio is a ratio of two odds. The odds ratio represents the odds that an outcome will occur given a particular exposure compared to the odds of the outcome occurring in the absence of that exposure. In this case, the odd ratio is 2.16. Odd ratio are relative risk estimates. It is a risk multiplier. Example, odd ratio of 5.64 suggests 5.64 times risk with exposure. And the odd ratio is a good estimate of the relative risk when disease is rare.